Hello students, how are all of you? I hope all your preparation is going on really well. So let us quickly see what the ENT questions were in the INI CET May, the last INI CET. Arrange the structures of the auditory pathway in the sequential order of sound transmission from receptor to center. Okay, so what is being asked is that we have to arrange the structures of the auditory pathway from the periphery to the center. Yes, we know that very nicely. We have first the cochlear nerve, then we have the cochlear nuclei, and then we have SLIM, S-L-I-M. What is S? S is superior olivary complex, L is lateral lemniscus, I is inferior colliculus, and M is medial geniculate body. And then we have the auditory cortex, the transverse temporal gyrus, area number 41, right? So now let us see what the choices are. Spiral ganglion, superior olivary complex, inferior colliculus, cochlear nuclei, lateral lemniscus, medial geniculate body. Okay, so first is cochlear nerve. Where is that? Cochlear nerve is not given here. What is given but? Yes, spiral ganglion. That is the ganglion for the cochlear nerve. So that is 1. Second is cochlear nuclei. Cochlear nuclei is 4. Superior olivary complex, where is that? Okay, so that is 2. Lateral lemniscus is 5. Inferior colliculus is 3. Medial geniculate body is 6. Okay, auditory cortex has not been mentioned. So if we will write this order, it is 1, 4, 2, 5, 3, 6. Let us see which choice has this. 1, 4, 2, 5, 3, 6. Okay, so that is in the choice A itself. So yes, this is a question that has been repeated the third time now. Previously, when it was asked, cochlear nerve was given. This time what they have changed just is that the spiral ganglion has been given instead of cochlear nerve. So coming to the next question, what is the grade of retraction? Okay, so here we have a picture of the tympanic membrane being given, and it is a spot diagnosis. We just have to see at the tympanic membrane, diagnose which grade of retraction it is. Okay, so at the picture, when we look at the picture, what are we seeing in the picture? We can make out that we are seeing the handle of malleus, right? The handle of malleus, this is the lateral process we can see, and we are seeing the cone of light. We cannot see anywhere clearly. We are seeing the distorted cone of light. And please note here, are you seeing something here? Something here. Now let me just rub it again. Okay, now let me rub this. Yes, can you make out some prominence here? What exactly is this? Yes, so always remember that whenever there is any picture of the tympanic membrane given or any middle ear structures that are given, an endoscopic picture, and you are supposed to identify what are the structures that you are seeing, what is the step that you have to follow? The first is always that you will have to identify which tympanic membrane it is, right? So, or which side of the ear it is. So, if this is the tympanic membrane, which tympanic membrane it is? Is it the right or the left tympanic membrane? How do we identify that? Yes, I have told you that we should consider the tympanic membrane like a clock, and the handle of malleus like the long arm of the clock with the arrow at the top. Whichever side the handle of malleus is pointing, it is that particular tympanic membrane, which means that if the arrow is like this, it is pointing towards the right side of this page, so this is the right tympanic membrane. If the arrow is like this, which means if the handle of malleus is like this, it means it is which tympanic membrane? It is pointing towards the left, so it is left tympanic membrane, right? Now in this endoscopic picture, let us see, this is the handle of malleus, so it is pointing towards, yes, it is pointing towards the left, so this is the left tympanic membrane. And also the second thing that we have to see is that which is the anterior part of the middle ear or the tympanic membrane, and which is the posterior part. Yes, so how do we come to know that? So what I told you is that the handle of malleus, wherever it is pointing to, it is that particular side of the tympanic membrane. For example, if I am taking this, right? If I am taking this tympanic membrane, I know it is pointing towards the right, so this is the right tympanic membrane. Also, whichever side the handle of malleus is pointing, that is the anterior part. Is that clear? So this is the anterior part. This is the anterior part and this will be the posterior part. Is that very clear? If I draw the opposite side, if I draw a tympanic membrane like this, the malleus is pointing like this, it means that this is the left tympanic membrane. That is the first thing I'm coming to know. And second thing, that this is the anterior part, right? This is the anterior pointed part. It always points towards the anterior part. Okay, now let us come back to this tympanic membrane. What we are seeing is that this is the left tympanic membrane, which is the anterior part. So this is the anterior part and this is the posterior part, right? So this is the posterior part, which means that one structure that we are seeing here very prominent, it appears as if the tympanic membrane is just touching that structure. What is that? That is present in the posterior part. So now we can easily localize, if we know that is a posterior part, what that structure is. What is the round structure that we can see in the posterior part? Yes, that is the head of the stapes. Is that clear? You are seeing the head of stapes. We are not seeing the incus here. Probably the incus is necrosed. Is the incus the most common ossicle to get necrosed? Yes, it is. So probably incus is missing here. We are seeing the head of the stapes, and we can see that the head of stapes is so prominent here because the tympanic membrane is just touching the head of stapes, right? So that is what we have. We are clear once we are seeing this tympanic membrane. Now let us see what the choices are. So the grade of retraction 1, 2, 3, 4. What is grade 1 retraction? Grade 1 retraction is when the tympanic membrane is just a little retracted. It is not touching the incus, right? So when it is not touching the incus, how can we see the tympanic membrane and know that it is retracted? Yes, what are the signs of retracted tympanic membrane? Yes, that the handle of malleus is retracted. It is foreshortened. So whenever the handle of malleus is foreshortened, how do you come to know that? Yes, the handle of malleus, whenever it is foreshortened, the lateral process appears very prominent. And because the handle of malleus is pulled inside, the lower part, that is the umbo, that you can see here, you're not able to identify very clearly. Is that clear? Okay, now also because of foreshortening of the handle of malleus, the malleolar folds, the anterior posterior malleolar folds, they appear prominent. Yes, and the cone of light is distorted. The cone of light is distorted or it is absent, and because of that, the tympanic membrane has a very dull appearance. So that is what is the one. That is what is stage 1, right? Now what is stage 2? Stage 2 means that the tympanic membrane has got retracted a little more deeper and now it is touching the incus or the stapes. So now we have, by seeing this picture, we came to know that it is touching the head of the stapes, and yes, that is 2. So the answer is 2, right? Now let us quickly have a look at how these retraction pockets look like on endoscopic pictures and what they are. Yes, as I told you that what is stage 1? Stage 1 is when the tympanic membrane is just a little retracted. So the handle of malleus also will be foreshortened. The features I just told you. Now what is 2? 2 means it is retracted little more medially, little more deeper is the retraction. So now it is touching the, let me draw it with a different color. Yes, now it is touching the incus, or we can see that the incus and the stapes, they articulate. So it can be touching either only the incus or it can be touching the stapes. Either is stage 2. Is that clear? Stage 3 means it goes further deep. Okay, further deep means it gets retracted further medially. Now it goes and lies on the promontory, right? That is stage 3. 3 means it is lying on the promontory. Okay, so when it is lying on the promontory, it means that the whole of the middle ear space has got obliterated. Means that the middle ear cavity has got collapsed. Yes, what do we call the collapse of the lung as? Atelectasis. So here also collapse of middle ear cavity is known as atelectasis. And what is stage 4? Stage 4 is the same, that the tympanic membrane is not touching the promontory, but it is not only touching, it has got adhered to it. Is that clear? It has got adhered to it. Remember this. Now I will ask you to identify. Okay. So yes, can you see here? This I have given a normal tympanic membrane. Only when you see what is normal, you can make out minimal abnormalities, right? So here what we are seeing here, this is which tympanic membrane? Yes, this is the right tympanic membrane, and also which is the anterior part? Yes, this is the anterior part. We can see the beautiful cone of light here in the anterior part, and in the posterior part, sometimes you are able to make out the glimpse of the long process of the incus, sometimes of a little part of the head of the stapes also, which we are not very clearly seeing. But even if we see that is, we can see that. But see how translucent and how good the normal tympanic membrane is appearing as compared to this picture. This is here you can see that the cone of light is not very good. The tympanic membrane is appearing dull. Yes, the handle of malleus is appearing foreshortened. This part you are not able to make out very clearly. The umbo part, yes, this is appearing a little more prominent as compared to see the normal anterior and posterior malleolar folds. Yes, so this is stage 1. You can see a glimpse of the long process of incus, but definitely it is not appearing to be touching the incus. Okay, now when it is touching, how will it appear? Just see that. Okay, now just see here. Now whenever you are seeing the tympanic membrane, yes, what is the first step to identify? Yes, the first step to identify is which tympanic membrane. So if I am talking about this tympanic membrane, this is the right tympanic membrane and this is the anterior part, this is the posterior part. Is that clear? Now if I am seeing this is the left tympanic membrane, this is the anterior part and this is the posterior part, right? So just a look can tell me, yes, in this patient, what we are seeing in this tympanic membrane is that in the posterior part, this is the posterior part, right, where the arrow is marking, the red arrow. So in the posterior part, we can see that the tympanic membrane is touching. Why I can say touching? Because the incus, we usually see just a glimpse, but here it is appearing so prominent as if it is draping. The tympanic membrane is draping the incus. Yes, so here it is touching the incus. Which one is the incus? This one. Okay, and also we can see it is touching the stapes also. Can you make out this part? Yes, this part. Now let me rub it. Yes, this part, this is the stapes. This is the stapes head. This is the stapes head. Right, so it is touching the incus as well as the stapes. Here what we are seeing is that incus is missing in the second picture. In this picture, the incus is missing and we can see it is touching the stapes head. So both these are stage 2. Right, now coming to stage 3. Stage 3 is what is when there is collapse of the miliary cavity and tympanic membrane is lying on the promontory, touching it, not adhered to it. This is atelectasis. And 4 is when it has got adhered to the promontory. Now, just by looking at the tympanic membrane, can you make out that it is just touching or it has got adhered? Just by a look of the endoscopic picture, can you make out that this tympanic membrane, which is appearing to be draping over the promontory, just see, definitely it will be first draping over the incus, stapes, and then it will go and lie on the promontory. So all the incus and stapes will appear very prominent. But here also we are seeing that this bulge, the promontory, that is also appearing very prominent here. So yes, it is lying on the promontory, whether this one or whether it is, we can see here also, yes, this is the anterior part and this is the posterior part. This is the handle of malleus like this. Yes. So this is the promontory part. Can you make out that this is just touching the promontory, it is adhered to it? No, we cannot. By just having a look at the tympanic membrane, we will never be able to make out that. How can we make that out? Yes, we can make that out by seeing that the tympanic membrane is mobile or not, by seeing the mobility of the tympanic membrane. And how do we check for the mobility of the tympanic membrane? Yes, that we do with the help of either Siegel speculum, or when we put the Siegel speculum in the otoscope. What is this procedure known as? It is known as pneumatic otoscopy. So what we are doing here is we are increasing or decreasing the pressure by pressing this bulb. Pressing and releasing this bulb, and this is used to test the mobility of the tympanic membrane. So when we are seeing an appearance like this and we do the pneumatic otoscopy and we find that the tympanic membrane is mobile, then it is with stage 3 or 4. Yes, then it is stage 3. Whereas if we see that the tympanic membrane is not mobile, then it is stage 4. Is that clear? So which means that if just a spot diagnosis is given, it can be either 1 or 2. If we want to differentiate between 3 or 4, any of the following should be mentioned, either atelectasis or just collapse of miliary cavity with the tympanic membrane touching the promontory, or adhered to the promontory, or on pneumatic otoscopy the tympanic membrane is mobile, or on pneumatic otoscopy tympanic membrane is not mobile. Yes, so only if these things are given, only then we will be able to differentiate whether it is 3 or 4. So now if we look at this picture again, so these are the steps that you have to follow. Nowadays, the identification of the structures of the tympanic membrane or the miliary structures are asked very commonly. So whenever it is asked, this is the step that you will have to follow. So yes, we can make out that here it is the grade 2 retraction. So coming to the next question, a patient is found to have acute vertigo and horizontal nystagmus with the slow component towards the left. In which of the following conditions would you see this finding? So what is this patient? It is a patient of acute vertigo, and this patient has a horizontal nystagmus. What is the direction of the nystagmus in this patient? Yes, read this carefully. Always read the questions calmly, carefully. So yes, what is given here is slow component is towards the left. Whereas what's the direction of nystagmus? Direction of nystagmus is always the fast component, right? So in this patient, the direction of nystagmus will be towards the right. Yes, that is the fast component. So here we have a patient who has acute vertigo, and on examination there is horizontal nystagmus to the right. Whenever we say horizontal nystagmus to right, it means that the direction is towards the right. Now let us see the choices. The first choice is posterior canal BPPV. Can it be a posterior canal BPPV? So always remember, this is the first thing that you have to remember whenever you have to answer such questions, is that whenever there is involvement of the vertical canals. What are the vertical canals? Vertical canals are the anterior and the posterior. Anterior is also known as superior semicircular canal. Yes. So whenever there is involvement of the vertical canals, the nystagmus is always a vertical nystagmus. Yes, and because it is the involvement of the inner ear, that is the peripheral pathology, nystagmus will also always have a torsional component. So if there is involvement, that is the first thing I am asking you to remember, that whenever there is involvement of vertical canals, nystagmus will be vertical, right? And what are the vertical canals? Vertical canals are the superior semicircular canal, which we also call as anterior semicircular canal, or the posterior semicircular canal. They are vertical canals, so nystagmus will be vertical nystagmus with torsion, right? With torsion. Whereas if it is an involvement of the horizontal canal, yes, horizontal canal involvement will lead to what type of nystagmus? It will lead to horizontal nystagmus. That is simple, right? Vertical canal, vertical nystagmus. Horizontal canal, it will always be horizontal nystagmus. So horizontal nystagmus. Horizontal nystagmus will be because of involvement of horizontal semicircular canal, and the other thing, another disease, another condition where there is horizontal nystagmus is when there is complete involvement, complete destruction of labyrinth of one side. So if the one side labyrinth has become completely hypoactive, completely destroyed, that will also lead to horizontal nystagmus. So whenever there is vertical nystagmus, what condition of with torsion, what condition of the inner ear will come to your mind? Yes, involvement of superior semicircular canal, involvement of the posterior semicircular canal. If there is a horizontal nystagmus with torsion, what will come to your mind? Yes, either involvement of horizontal semicircular canal or complete destruction of labyrinth. Is that very clear? Complete destruction of labyrinth of one side, right? Okay. So now let us see the choices. The first choice is posterior canal. We know that's a vertical canal that cannot lead to horizontal nystagmus. The second choice is superior canal. Superior canal again is a vertical canal that again cannot lead to horizontal nystagmus. The next choice we have here is right hypoactive labyrinth, and the D choice is left hypoactive labyrinth. So can the direction of nystagmus also tell you the pathology of the ear? Yes, it can tell you. Yes, so that is another important thing that you need to remember here, that the direction of nystagmus is always towards the more active side. And what is the meaning of direction? Direction means always the fast component. Direction means fast component, right? Direction means fast component, and it is always towards the more active side. Now listen to this very carefully. When I say more active, what does it mean? If one ear is hyperactive and the other ear is normal, what becomes the more active here? More active becomes the hyperactive. So then the nystagmus will be towards the hyperactive side. Whereas if the one ear is hypoactive and the other ear is normal, then what becomes more active? More active becomes the normal side. So here the nystagmus will be towards the normal side, which means that if here is a patient who has a horizontal nystagmus towards the right side, what are the two DD that you have? Then it can be either Same side hyperactive lesion, right hyperactive. Yes, or it can be a left hypoactive. Hypoactive lesion, is that very clear? Yes. So what is the diagnosis here? It is a left hypoactive lesion. Yes. Or if in the choice was given right hyperactive labyrinth, then we could have also marked right hyperactive lesion. Now these questions are being asked very, very commonly from you. So let us quickly summarize and repeat what I have told you. What I have told you is that whenever question of nystagmus is given, the first thing you will see is whether it is a vertical or a horizontal nystagmus. Whenever there is involvement of vertical canal, that will lead to vertical nystagmus. Horizontal canal involvement will lead to horizontal nystagmus, and complete destruction of labyrinth will lead to a horizontal nystagmus. Which side is the lesion? How can you come to know? Yes, the direction will tell you. Direction is the fast component, and direction is always towards the active side. Which means that if it is towards the right side, it means right is more active, or that is right side is a hyperactive lesion, or the left is hypoactive. So left is the hypoactive lesion, right? Now let us see this example. Now if I tell you that there is a patient of right posterior canal BPPV, tell me the type of nystagmus that this patient will have. The patient has a right-sided posterior semicircular canal BPPV. Yes, tell me what will be the nystagmus. Yes, first posterior canal, so it will be vertical. So it will be a vertical nystagmus. Yes, vertical nystagmus, and it is a BPPV. BPPV is hyperactive or hypoactive. It is a hyperactive lesion. The only thing that you need to remember in hyperactive is BPPV. Yes, so it is a hyperactive lesion. So nystagmus will be towards the same side. Which side is it? Right side. So it will be a right side vertical nystagmus, or a vertical nystagmus. Yes, definitely with torsion, but towards which side? Towards right side. Similarly, if vestibular neuritis. Yes, what is vestibular neuritis? If I am telling you that this patient has a right vestibular neuritis, what will be the nystagmus and how will be the nystagmus? What will be the direction of nystagmus? Vestibular neuritis is an inflammation of the vestibular nerve. So complete one side of the labyrinth becomes hypoactive. One side nerve is gone. So one side complete labyrinth becomes hypoactive. So in that case, vestibular neuritis, complete destruction of one side labyrinth or complete involvement of one side labyrinth, that will lead to horizontal nystagmus. So here the patient will have a horizontal nystagmus. And towards which side? If it is involvement of the right side, right becomes the hypoactive side. So nystagmus is always towards the more active side. So horizontal nystagmus towards the left side. Is that very clear? Yes. Now recently was another question that was asked in your exam, and that was again an INI CET. What was asked was that you are giving cold water, you are doing during caloric test, you are putting cold water in the right ear. Yes, what will be the nystagmus? Okay, so that seems so simple, right? Okay, cold water is, we remember that is cows, yes. So immediately we can see and tell cold is, yes, is towards the opposite side. Cold, it is towards the opposite side, yes. But look at the choices. What were the choices? Horizontal nystagmus towards the opposite side, or horizontal nystagmus, it was given in the right ear. So horizontal nystagmus towards the left, horizontal nystagmus towards the right, vertical nystagmus towards the left, vertical nystagmus towards the right. Now can you tell me what the answer will be? Horizontal nystagmus or vertical nystagmus? Yes, so in caloric test, do you know which semicircular canal you are stimulating? Yes, we are stimulating the horizontal semicircular canal. So the nystagmus will be, it will be a horizontal nystagmus. Horizontal nystagmus, and when we are putting cold, we know the nystagmus will be towards the opposite side. So it is a horizontal nystagmus towards the opposite side. Yes, so now I am going to ask you that cows, when we remember this cows, with cold water nystagmus towards the opposite side, and with warm water it is towards the same side. Does this also follow the rule that nystagmus is towards the more active side? Is it following the rule? Yes or no? Yes, it is following. Whenever we are putting cold water in anybody's ear, what are we making? What we are doing to the labyrinth, that particular ear? Yes, we are, by cold water we make the labyrinth hypoactive. And then we see that if the labyrinth is functioning normally or not. If it has become hypoactive, is it producing a nystagmus towards the more active side, that is the opposite side, right? Similarly, when we are putting a warm water, what are we doing? With warm water, we are making the labyrinth hyperactive. So what we are seeing is when we are making a particular labyrinth hyperactive, is it responding appropriately how it should respond? Yes, so when we are making a labyrinth hyperactive, nystagmus should be always towards the more active. Which is the more active here? The hyperactive. So when we do warm water, always nystagmus should be towards the same side. So this always we remember. But what is happening here? I just told you nystagmus is towards the more active side. That is what you need to remember. Right? Now these questions these type are likely to come in the future also. So this is how, and this is what you have to remember. This is how you have to come to a diagnosis. So coming to the next question, again a very favorite on laryngeal carcinoma. So here it is, what is the radiological staging of this patient with laryngeal carcinoma? Again, it is just a spot diagnosis. Now whenever such types of questions come and it is a spot diagnosis and you see the picture, the first thing you do is that panic. Oh my God, what is this? I have not seen this earlier. So the first thing that you should do is don't panic, stay calm, see what is given in the picture. There will be nothing which you will not be knowing. Yes, so here it is, what is asked is the staging of a laryngeal carcinoma. So we know that what we are seeing is a cut section, an axial cut section, that is a transverse cut section at the level of the larynx, right? So this lumen that we are seeing is the larynx lumen. Behind the larynx will be the hypopharynx, right? And here anteriorly, what will be this? This is the thyroid cartilage. Thyroid cartilage. So what we are seeing here is that there is complete erosion, through and through erosion of the thyroid cartilage. The complete cartilage appears to be missing. So now you already know the stages very nicely, right? What the stages of laryngeal carcinoma are. So tell me which stage it will be according to you before we see the choices. Yes, if the carcinoma of the larynx has gone outside the larynx, but it is local, like it has gone completely out, it has invaded the thyroid, eroded the thyroid cartilage completely. Yes, it has gone out. That is T4. That is the fourth stage, T4. Yes, so that by seeing this picture, we have an idea that this is T4. Now let us come to the choices. Okay, so what is the choices? It is T1, N1, M0, T4, N1, M0, T2, N1, M0, T3, N1, M0. Okay, so we feel that the answer is going to be B, T4, N1, M0. What we are noticing is N1 and M0 are same in all. Even if it was not, please focus only on the T1, T2, T3, T4, because you will never be expected to identify a neck node involvement to count whether it is 1 or 2 or how many ipsilateral, bilateral on a CT. You will not be expected. We can do that, but you will not be expected to do that. Yes. So whenever even one is N1, one is N2, one is N0, do not get confused. Just focus on whether it is T1, T2, T3 or T4 which has been given in the question. Now when we see the first choice, it is T1. We are more or less as the answer, but let us just try to see what the other choices are. Now here first choice is T1, N0, M0, right? What is T1? What is T1 of a carcinoma of the larynx? Yes, T1 is when it has involved only one site or one subsite. One site means what? One site means, what are the three sites of the larynx? Yes, the three sites are the supraglottis, the glottis and the subglottis. So if it is involved only one site, means either only the glottis or only the subglottis, or when we talk about the supraglottis, there are so many areas, subsites in the supraglottis. So involvement of only one subsite in the supraglottis is T1, right? So only the glottis or only the subglottis, or if we talk about supraglottis, then only one subsite. That is what is T1. Now just tell me that when you are seeing this picture of one axial cut section, only one film has been given to you, yes or no? Only one film has been given to you. In that film, just by seeing that film, can you tell that there is involvement of only one area or there is involvement of more than one area? No. To see whether there is involvement of more than one area, you need multiple films. Yes, and also you might need a coronal film. This one axial film will not tell you whether this is the only involvement or there is involvement of other areas also. So which means that on one axial section, we cannot find out whether it is T1 or not. So this can never be. We are almost at the answer. We know that the answer is T4. But still I am telling you so that there should be no ounce of any doubt in your mind. Yes, you don't have to rectify anything, you have to understand. Yes. Now, what is T2? T2 means that the tumor has gone to the adjacent. 2 means it is not involving only one, it is more than one. You can remember it as 2. T2 means 2. 2. It is involving 2 areas. 2 areas means which areas? Yes, it has to be adjacent. Definitely, if from one area it is going to the other area, it will not jump to from the subglottis to the supraglottis. From the subglottis is going, it will go to the adjacent area only, that is the glottis, right? So if from the glottis it has gone to the subglottis, or from the glottis it has gone to the supraglottis, that is what is T2. Or if we talk about the supraglottis, if from one subsite it has gone to the other subsite, means if from the epiglottis it has gone to the aryepiglottic fold. Aryepiglottic fold, this is adjacent. So if it is involving more than one site or more than one adjacent site or adjacent subsite, that is T2. Now again, can you tell me that if we have one film, we already saw we cannot make out whether it is one area involved or more than one area involved, which means in one axial film, we definitely cannot differentiate whether it is a T1 or a T2. T2 also we will not be able to find out. So this also can not be the answer if one film is given, right? Yes. Now let us come to 3. And yes, T2 is also if the vocal cord mobility is impaired. Impaired means it is moving but not freely. There is some impairment of the mobility. Will that you be able to appreciate on a CT scan? No, that is an endoscopic on visualizing the vocal cord. So anyway, in one film you cannot make out, and whether the impairment of vocal cord, that also you cannot make out on a CT. Now coming to T3, what is T3? T3 means that when there is fixity of the vocal cord. Can you see fixity of the vocal cord on the CT? No, we cannot. Now T3 can also be when the tumor has gone. Yes, T3 can also be when the tumor has gone either in front, that is pre-epiglottic space, or to the paraglottic space, or to the post-cricoid, all around, right? Pre-epiglottic, paraglottic, post-cricoid, and in forward, it can also be involving the thyroid cartilage, but just the inner cortex, right? Just the inner cortex of the thyroid. Just the inner cortex of the thyroid, right? Okay, so now let us come back to this picture. Yes, vocal cord mobility we cannot find out on one axial cut section. Just the involvement of pre-epiglottic, paraglottic, post-cricoid or inner cortex of thyroid. Again, you will not be expected to identify on a CT scan. Is that clear? See, we have to be very true about what is expected out of us and what is not expected out of us. And believe me, they have never asked anything which is not expected out of you. Yes? So, which means that T3 also, we will not be able to identify, you will not be given on a CT scan to identify the pre-epiglottic, paraglottic, inner cortex of thyroid or the post-cricoid area. Yes, if it is mentioned in the question, that is different. But if it is spot diagnosis, these things you will not be given. And vocal cord fixity, which is the main criteria, very important criteria for labeling a tumor of the larynx as T3, we never see that on CT. We see that only on endoscopic examination, which means overall, what is the summary? Summary is that if a film is given, only one axial film, you cannot find out T1, not T2, not at your level, not T3 also. Yes, so it has to be T4. What is T4? T4 means that the tumor has gone out of the larynx. Yes, when it is local, local means it has gone to the strap muscles or to the thyroid gland, invaded the thyroid cartilage completely, or locally if it has gone below to the trachea or posterior to the esophagus, that is T4. That is still operable, that is T4A, right? And T4B is when it has gone to distant places like which makes the tumor inoperable, like the mediastinum, carotid sheath, base of skull, all these things, or prevertebral space, right? So all that is T4B. So I hope that this is clear now, and whenever such a picture comes to you, then you are not going to get confused, and we know that the chances of repetition of the same topic or the same question is very high in INI CET. So you need to be very clear with each and every point of each and every question that has already been asked. Those were the 4 questions of the INI CET. And yes, just to conclude, one more minute of yours I will take. Yes, do you know what is going to happen tomorrow? Maybe yes, maybe no. Yes, but you can never definitely predict what the future is going to be, what even tomorrow is going to be. Yes or no? Yes, you can never predict the future. So if you are just thinking about whether I will be able to clear or not, whether I will be able to complete my course or not, whether tomorrow I will be able to finish, or you are just making up stories that I will finish this tomorrow, I will do this. Yes, believe me, you are doing only three things. What? You are creating fear, you are creating anxiety, and you are wasting your precious time. So the golden rule always is that what you should be doing is, instead of thinking of the future, yes, focus on only today, this hour, or this moment. Choose. Yes, only this moment. Take care of this moment and give your best no matter what the situation is. We do not know what is going to happen tomorrow, but one thing you can promise to yourself is, no matter what happens, no matter what the situation is, you will give your best, whatever best you can in that particular moment. Yes, so if you take care of every moment, believe me, the future is going to take care of itself.